Hi, everyone. Welcome to this virtual Infectious Disease Congress sponsored by Johns Hopkins University School of Medicine and ID Care Live. My name's John Bartlett. You are tuned into a live CME session called HIV Prevention and Treatment Research. I'm with Drs. Paul Sachs and Cal Cohen. Dr. Sachs is director of the HIV Program, Division of Infectious Diseases at the Brigham and Women's Hospital in Boston. He's also associate professor of medicine at Harvard Medical School. Dr. Cohen is research director of the Harvard Vanguard Medical Associates and Community Research Initiative of the New England in Boston, Massachusetts. He's also a clinical instructor at Harvard Medical School. Before I get started, I would like to remind you that we will be taking questions in real time throughout the presentation. You can send us your questions anytime during the program and use the box in the lower left-hand corner of your screen to write in the question. We'll take them after each presentation, providing time allows. We're going to start with Dr. Cohen, who's going to give the first presentation. Cal?
Great, thanks very much. Thanks, John. So what I'd like to do is review some slides with you, and in these slides we'll have a chance to review some recent antiviral data that I'll be focusing on. So let me just get that first slide, please. But I think the first study that I was planning to present is in some ways both an issue in study research as well as the data itself, which is the question as this, which is if we are doing double-blind studies of our treatments and we are not prescribing medicines in a double-blind manner, how do the data from studies apply to clinical reality? And the example of rilpivirine is a recent pertinent example. The studies ECHO and THRIVE tested rilpivirine versus efavirenz in a double-blind manner. Patients took a rilpivirine tablet, they took an efavirenz tablet, and they took their nucleosides. The patient didn't know what they were taking. We don't use that in clinical medicine. I give you a tablet, you know what you're on, I know what you're on. If you're on rilpivirine, you know to take it with food, you know how to take the efavirenz. So we had guidance with that. And so now we have two studies, one double-blind, one open label, and we'll have a chance to take a look at the results as soon as the slides come up to see with how the drugs reveal themselves, both with the simplicity of open label as well as the complexity of double-blind. So it'll be an interesting outcome for the field. And I think our audience is seeing them. We're just waiting for us to be able to have a chance to see them as well.
Yeah, interesting point that you're raising.
It reminds me, I don't know if you remember, but we were, amongst a few of us, trying to remember the last time that we could think of that a regimen was studied both double-blind and open label to see how they compared. And I don't know if you can remember one. Go ahead.
I remember it was the trizavir versus indinavir studies.
Exactly.
And there we were looking at, what was really the simplicity of trizavir was its strength. And so if you did it in a double-blind fashion, the people who got trizavir got all these extra pills, and maybe that kind of hampered the trizavir somewhat. So it was done twice.
Exactly right. And so it's really kind of a revisit of that same question, which is what happens when we allow things to be as simple as they are and see what they do. You lose the benefits of blinding, you lose some of the kind of protection from the blinding, but you also gain something.
The answer to that question is really timely, isn't it?
Mm-hmm.
Because we're sort of talking about one pill versus two or three pills as an economic issue.
That's right.
And knowing if there's a difference with taking the same pills, but one versus three.
Right.
It turns out to be a real critical question.
These days it's really critical.
Yeah. Are you going to give us a hint, or are we going to wait for these slides? We may be here tomorrow.
Well, maybe give the results.
Should we give the results? All right. Well, so I'll describe them with the hope that it looks like we're getting some access to the slides there. So good. So I think if our
why don't we
audience
put
is seeing
that
them-
here?
Yeah.
Oh,
good.
we can't see it.
All right. Well, I can see that one. I know them well. That's good. So if we're assuming that I think our audience can see them, so let me narrate these slides as they are here. Great. So the study that I'm going to be discussing is STAR. STAR is a simple single-tablet randomized design. Patients got either open-label tenofovir FTC efavirenz, Atripla, or they got the open-label tablet that we know as Complera, single-tablet tenofovir FTC and rilpivirine. The patients knew what they were taking. We knew what they were taking. Therefore, if they got rilpivirine, we could stress taking it with something to eat. They had the efavirenz, we could stress the opposite. So we had the ability to kind of ensure adherence the best that we can. A side note, by the way, is that at the Glasgow conference where this was presented, we also learned that rilpivirine is absorbed adequately with a meal that's at least 390 calories. It doesn't have to be more than that. 390 is enough, and it turns out 390 is actually not that much,
Not that much.
for almost any meal at all. So the design is a simple one. It's a large trial, nearly 800 patients randomized between these two arms. The trial was done worldwide. There were actually 12 different countries that participated. The entry CD4 count is on the high side of close to 400 on average, as is true with many of our trials. The viral load was around 4.6, like about 60,000 for both arms. About two-thirds of the patients had a viral load less than 100,000, but a third came in above 100,000. That's a critical issue because there were concerns from ECHO and THRIVE about the performance at high viral loads, and it turns out a third of the patients came in above 100,000 indeed. Almost 10% were randomized with a viral load over 500,000. So we're going to have a chance to take a look at the results broken down by baseline viral loads. So if I see the next slide, if you will just click that to one over. Perfect. Here's the primary results. At the end of week 48, the primary objective is shown on this slide. As you can see, 86% of patients on rilpivirine had virologic suppression, 82% on efavirenz. If we take a look at that point estimate and the confidence interval, that 4% difference favoring rilpivirine, the confidence interval, the lower boundary is -1%, certainly demonstrating non-inferiority for the rilpivirine single tablet versus the efavirenz. The reasons for not being virologically successful are shown on this slide. Virtually the same amount of virologic failures. You can see around 7% for both arms, but there is more lack of data at week 48, which is a composite of adverse event dropouts and administrative dropouts. So let's take a look at now a little bit more detail. You'll see the CD4 results here. Both arms increased by 200 cells. The next slide is the primary outcome now stratified by a viral load of 100,000. And you can see on the left that on rilpivirine, for patients whose baseline viral load is less than 100,000, 89% on rilpivirine are virologically successful, 82% on efavirenz. The confidence interval for that is on the right side, and as you can see, 7% difference favoring rilpivirine. The lower boundary of the confidence interval is now +1%. Suggesting statistical superiority for this. And the reasons for the superiority I'll show you on the next couple of slides. If we take a look at above 100,000, you can see it's 80 versus 82%, smaller n, wider confidence interval, but the lower boundary still doesn't exceed -12%, demonstrating non-inferiority for that group. Now, the FDA had, in the ECHO and THRIVE trials, required us to look at 3 strata, less than 100,000, 100,000, or 500,000, and greater than 500,000. And because we didn't know how many patients would come into this trial in those higher ends, we left it open to enrollment to see what we had. Since we do have some data in that, let me demonstrate to you now what the efficacy was. You can see at the bottom of this slide that virologic suppression in that middle tier, 100,000 to 500,000, was the same for rilpivirine and efavirenz, both in that middle 80s. It's only when we got to the highest high viral load, greater than 500,000, that we start to see the decline for rilpivirine at, as you can see, around 72% versus efavirenz maintaining closer to 80%. Now, the next slide actually takes this to one more level of detail. Because virologic success is one thing, virologic failure is another. Let's take a look at virologic failure as the reason for not being successful, as opposed to the administrative dropouts and the adverse event dropouts. What we're doing on this slide is comparing the STAR results to ECHO and THRIVE. You can see that for patients who entered less than 100,000, virologic failure for rilpivirine and efavirenz is the same whether they were on the ECHO and THRIVE trials or the STAR trial, 5% for rilpivirine, 3% for efavirenz. What's striking is how different it is in that middle tier. Greater than 100,000 to 500,000, the rate of virologic failure for rilpivirine is 10%, for efavirenz it's 9%, virtually identical. In contrast, in ECHO and THRIVE, it was 20% for rilpivirine and 11% for efavirenz. So there's a real difference there, and rilpivirine does better when it's given in the way that we would give it, with all the attention to detail and adherence. Now, greater than 500,000, we do see more failure on rilpivirine than efavirenz. So clearly, there is a viral load effect for rilpivirine. It is not the ideal drug for the highest high viral load, but there is something interesting happening in that middle tier that's different from the impression we had from ECHO and THRIVE. It's much closer than we had initially seen. So the next slide just has the last piece of detail on this, which is the issue of not just virologic failure, but virologic failure plus resistance. Quickly summarizing, you can see that if there is virologic failure, there is going to be some resistance on both of these drugs, but there's a relationship between baseline viral load and the likelihood of resistance. For patients who entered less than 100,000, 2% of patients develop resistance on the rilpivirine arm, 1% on efavirenz. In the middle tier, 100,000 to 500,000, 5% develop resistance on the rilpivirine arm. Nobody actually on the efavirenz arm developed resistance in that middle tier. At the highest high viral load, once again, we see more resistance on rilpivirine, nearly 20%. Parenthetically, I'll point out that in the lower bucket, in the less than 100,000, those 2% of patients develop Y181C mutations. We actually didn't even see 138K in those very few patients. So I think in summary, what we're seeing here is that as we use rilpivirine in a clinical setting, the question is, what is the right patient for this drug? And this study would certainly support that less than 100,000, this is performing as well as efavirenz. But it also did better in that, but may be better. So let's look at why it's better, because it isn't a virologic reason, it's actually a tolerability reason. And the next slide summarizes the tolerability differences. As you can see here, there were statistically more patients who were successfully suppressed and tolerating rilpivirine than efavirenz. You can see here far fewer cases of nervous system events, far fewer psychiatric toxicities. And the bottom line, on rilpivirine, 10 people, about 2%, dropped off rilpivirine for tolerability problems, and about 9% on efavirenz. That 7% difference is what accounts for the superiority at that lower viral load. So what we have here is a composite picture of better efficacy in that kind of middle tier, close to 100,000 group, and low rates of resistance, although albeit a little bit more in rilpivirine than efavirenz. But we also see it's a better tolerated drug, and that allows for statistical superiority in that lower group. Something now is, yet again, doing better than a triplet at creating successful virologic suppression at the end of a year. So it's an interesting study for the field to kind of decide what we want to do with this drug as a result. So let's take the next slide. The next use of rilpivirine is in virologically suppressed patients, suppressed in this particular study on a boosted PI. This study was updated. It had been presented earlier this year and is now updated for the field. Again, to be successfully in this trial, somebody had to have a virus that would be susceptible to rilpivirine and their nucleosides, so no history of virologic failure that would confer resistance. They were successfully suppressed on a boosted PI, and the randomization is simple. Stay on the PI or switch to rilpivirine, tenofovir FTC as the single tablet Complera. Patients did that, and then 24 weeks later, those patients who were on their PI were allowed to cross over. So we have a year of follow-up for one group, 24 weeks for a second switch for the other group. Now let's take a look at the results. The results are confirming what we saw at week 24. If a patient switches to rilpivirine after they're virologically suppressed on a PI, they maintain suppression virtually always. At week 24, there was actually a little bit of blipping on the PI. There was less blipping on the rilpivirine-based tablet. At the end of a year, the rates of virologic failure are quite low on rilpivirine, and so it confers this degree of confidence to the regimen overall. And of note, at least in vitro, we did know that patients who had K103N in vitro had susceptibility to rilpivirine. This study was done in patients who, if they were allowed into the study, they had no prior non-nuke use. But it turns out that a number of patients, 24, had transmitted drug resistance. They had K103N on a pre-treatment genotype, but had never taken a non-nucleoside. Of note, almost all of them were virologically successfully suppressed after switching over to rilpivirine, conferring a degree of confidence again that at least in transmitted drug resistance, rilpivirine is useful in that category. And it just confirms our in vitro impressions. The next slide gets into a little bit more of the issues around resistance. There were a few patients on rilpivirine who had virologic failure, and the bottom line at the end of the year is that there were 4 patients on rilpivirine who had virologic failure with resistance. One of them turns out to have the K103N rebound mutation, and it turns out this person should not have been in the protocol. Yeah. On review, they had a pre-use of efavirenz prior to entry to the study, so it's a violation. One person had only 184V, 2 patients had the typical rilpivirine resistance mutations. Again, suggesting that in patients successfully suppressed, rilpivirine is very successful at maintaining suppression in virtually all the patients for approximately a year, the duration of these results. The next slide goes into then the benefits of the switch, because all of these are showing why you can, not why you should. In this study, patients could be on Kaletra, atazanavir, they could be on darunavir, and broken down by all PIs collectively, the lipid improvement is illustrated on this slide, the switch to rilpivirine, and you can see on the right the key issue perhaps of total cholesterol to HDL ratio, which in this study shows a significant improvement favoring rilpivirine versus maintaining on the PI. You can see the benefits in the LDL fractions as well, suggesting that for some patients, not only can they do this for simplicity reasons, but there may be a beneficial effect in terms of lipid outcomes. Now, the next slide here that we're going to get into is one more new drug I wanted to briefly discuss. We've only all heard about it through a press release that Gilead issued the end of October, and it's pretty exciting. Earlier in this year, we were talking about 7340, which now has a name, tenofovir alafenamide. It is a new and improved tenofovir. Tenofovir, of course, is the active moiety. It has a new salt called alafenamide. It was studied in a randomized comparison in a phase 2 size trial in patients who would get the elvitegravir cobicistat single tablet. They got that tablet either with tenofovir, as we know it, disoproxil fumarate, or this new salt, the alafenamide salt. And the phase 2 results were released, and it's striking. You can see here, virologically, they both did well, both close to 90% successfully suppressed. But the safety differences is what's remarkable. What was reported is statistically significantly less changes in renal function with the new salt versus disoproxil fumarate, and benefit in terms of bone mineral density. There's less of an impact on bone mineral density with this salt versus disoproxil fumarate. So we're seeing exactly what we were hoping to see, which is that this, because of the lower dose, has less systemic exposure and therefore less of the toxicities that we learn to monitor for tenofovir. So it'll be very interesting to see now what happens to this molecule going forward in phase 3 studies. The next slide is, I think, going to turn the baton over to Paul. Unless you want to take any other questions, I'll turn it over to Paul.
Well, the major question I have is, are we going to get the slides? And this was written at 3:06, so it's 10 minutes ago, 15 minutes ago. I just want to make sure that the audience is seeing the slides. The answer is yes, so that's an outdated thing. Is Complera safe during pregnancy?
Good question. What we know is that Complera or rilpivirine got a Category B from the FDA. So what we know based on the assessments that we had, other than women who are pregnant themselves, what we have from animal studies is that it appears to be safe. We, however, don't have human experience with this drug yet. There is, of course, the pregnancy registry for any woman who becomes pregnant while taking the drug. All we can say is that based on what we know in the absence of human experience, the drug appears to be safe. We don't have PK data in pregnant women to know about dosing. So again, I think the caution is, as usual, use only if the potential benefits outweigh the potential risks.
Okay. Paul?
Sure. So what I'm going to do is I'm going to discuss first the sort of updated information on the 4-drug co-formulated tenofovir FTC elvitegravir cobicistat tablet, or quad. Or Stribil, those studies, the 96-week data, and then I'll shift to talk about a new integrase inhibitor, which is dolutegravir. And if I could get the next slide, please. The thing about this co-formulation is we already have published 48-week data on it, and now we're going to see 96-week data. And what can we learn from 96-week data that we don't already know from the 48-week data? Well, one thing we can learn is it's still working. Another thing we can learn is what's the adverse event profile long term? And is there kind of an emerging sort of feeling of either reassurance about the adverse event profile, or is there sort of more toxicities with longer exposure? So let's see the next slide, and we'll get the study designs. These are probably already familiar to our audience. There were 2 fully powered non-inferiority studies that compared this 4-drug combination, elvitegravir cobicistat tenofovir FTC. One study compared with tenofovir FTC efavirenz, Atripla. The other study compared with ritonavir boosted atazanavir. Of course, they also received tenofovir FTC. And as I mentioned, these studies were already published. They already demonstrated non-inferiority. We already know about the baseline characteristics, very much like in the study that Cal just mentioned, the STAR study. Next. And what's encouraging is that, let's take a look here at the study compared with efavirenz, is that the outcomes are still demonstrating non-inferiority. This is a durable effect. You know, it's not statistically significantly better, but it clearly meets the non-inferiority threshold. The lower bounds of the confidence interval is well above the -12%. There's no sharp increase in virologic failures, nor there's a lot of increases in adverse event dropouts or administrative dropouts. So encouraging to see these 96-week data. Next slide. So yes, and just a similar for the other study. Interestingly, I think the differences between the single pill and the boosted atazanavir were less marked than the single pill elvitegravir Cobi versus Atripla, and perhaps that's because the cobicistat is in some ways very similar to ritonavir. Next slide. So one area where we, of course, are going to look at the antiviral efficacy more carefully is in the patients who are typically harder to treat, and those are people with high viral loads or people with low CD4 cell counts. And in both of these studies, and I just put this slide up here for representation, that there's no evidence that this four-drug pill, I keep calling it the quad because I can't get rid of that habit, that it's actually just as effective as its comparator in the high viral load group and the low CD4 cell count. Reassuring data. Next slide, please. So one area that is very important is adverse events. And why do people drop out of these studies long term? Well, the good news is that there still are very few dropouts for adverse events in all of the comparators. And one area in particular for us to focus on is the renal adverse events of tenofovir, FGC, elbapixant, cobicistat for a couple of reasons. First is because cobicistat, we know, raises serum creatinine a little bit by inhibition of tubular secretion of creatinine, and that's a benign effect. But then also, patients who are receiving tenofovir-based regimens can have tenofovir tubular toxicity, and there was some seen in in both of the studies, a bit more in the study compared with a triplet than boosted atazanavir. And what this slide demonstrates is though there were 2 additional patients who were actually defined as having renal events in between week 48 and week 96, they actually were not patients who demonstrated tenofovir-related tubulopathy. So encouraging to that extent, and then there are also additional data that shows, and I'll show these soon, that over time the creatinine remains stable between week 4 and week 96. Next slide. These are those data. These are just changes in GFR. Most of the change that we see when we start someone on a elbapixant cobicistat-based regimen is going to happen very early. And we know now from the study that it's about a 0.14 milligram per deciliter change. Happens quickly. It happens at week 4. It then stabilizes over time. And that in the package insert, there's some guidance about how to manage this, and it basically advises clinicians that if there's a change of 0.4 milligrams per deciliter or greater, that's when one should be more concerned that there might be some actual tubular toxicity from tenofovir. Clearly, something that we do already, which is monitor patients' renal function when they're on antiretroviral therapy, is worth doing for this drug as well. Next slide. So this looks at the incidence of gastrointestinal side effects over time, looking at diarrhea and looking at nausea. Remember, the one subjective side effect that was more common in patients who received quad versus received a tripla was nausea. It was predominantly mild nausea, and you could see the onset of it was relatively early in the study and then did not occur very much thereafter. So this answers the question that we were asked multiple times. Well, is it nausea that persists all along, or is it just nausea early on that then get counted as nausea for the duration of the study? And actually it was more the former. And our experience in clinical practice since this drug was approved is that, in fact, this is generally very mild. Most patients tolerate this extremely well, and that it's not a common cause of drug discontinuation at all. The same is true for the diarrhea. It's just very low GI toxicity. Next. And when you look at central nervous system adverse events, not surprisingly, in the study where it's compared with a tripla, there is some central nervous system adverse event that occurs in the quad arm, and that's because patients were blinded. So they were told there's a 50% chance they might get some CNS adverse events. And as I mentioned, when people are told you might get this adverse event, there's the nocebo effect. So even if they're not getting the drug with the CNS toxicity, they might have some. But clearly, as these figures show, there's a much higher rate of CNS adverse events in the patients randomized to the efavirenz arm than the patients randomized to the quad. Next slide. And then one of the kind of surprising findings in the study, and here's a combined analysis, this actually was not presented in Glasgow, but was presented earlier this year at ICAC, is taking a look at the changes in the fasting lipids. Since, as I mentioned before, cobicistat has some similarities to ritonavir, we might expect it to have some of the adverse lipid profiles associated with ritonavir, but encouragingly, at least when combined with elbapixant, tenofovir, and FTC, if anything, the lipid changes in this treatment are more favorable than those seen with tenofovir, FTC, efavirenz, and very comparable to those seen with boosted atazanavir, although you can see that the triglyceride increase with boosted atazanavir was somewhat higher. So next slide is basically a summary of this single pill treatment that we now have. It's our third single pill treatment. The brand name is Stribild, and it's basically a co-formulated pill that's about the same size as a tripla. It's a little bigger than Complera. It has been shown to be non-inferior virologically with two other regimens, tenofovir efavirenz, tenofovir boosted atazanavir. These are both preferred regimens. One pill daily with food. It doesn't necessarily specify what's the size of the meal it is, but it should be taken with food. It does cost more than a tripla, and I put the cost of, at least the wholesale cost here. And it should mention that this cost is intermediate between the atripla cost and the cost of a boosted protease inhibitor-based regimen and a raltegravir-based regimen. So it's around the same as those. It does have a drug-drug interaction profile that we have to assume, at least for now, is comparable to ritonavir-boosted PIs. And we also have not studied this in patients with moderate or worse renal function. So this study inclusion criteria in this study was GFR greater than 70, and we know that if someone develops renal impairment on this drug, they should have the drug discontinued. Because it hasn't been studied in that population, and because there were relatively few women in this study, there are studies planned and ongoing in patients who have some degree of renal insufficiency and in women as well. One important caveat is the use of this drug with other protease inhibitors. Clinicians might be tempted, for example, to combine it with darunavir because that would make a very kind of compact way of treating a treatment-experienced patients. However, interactions between darunavir, cobicistat, and elvitegravir are highly complex and really not well worked out. And so right now it is not recommended that this be used except on its own as an isolated treatment. I should also mention there are switch studies ongoing. That's a different issue only, but do not combine this with other protease inhibitors. Okay, I'm going to shift now and talk about another integrase inhibitor, and that's dolutegravir. Within the past year, we've gotten very interesting data on this drug. I'm going to summarize some of it in the next few slides. The first of these was presented this summer in the International AIDS Conference in Washington, D.C., very nearby. It was a comparison between dolutegravir, a once-daily integrase inhibitor, and raltegravir, our already approved twice-daily integrase inhibitor that we've had since 2007. Study subjects were treatment naive. They were then randomized to one of these two in a blinded fashion, and the investigators could choose the nucleoside analogs. They could use either tenofovir FTC or abacavir 3TC at their preference. And because the data have been presented before, I'll cut right to the results. Next slide, please. The results clearly demonstrate that this is non-inferior to raltegravir. Very high response rates for both study arms, high 80s. Also, another important finding in this study, very well tolerated, very few discontinuations for adverse events. I do want to mention parenthetically, we did see some data in Glasgow that looked at the differences in response rates, whether the patients got abacavir lamivudine or whether they got tenofovir FTC, especially by viral load, because of our findings in 5202 that showed that at least with efavirenz and boosted atazanavir, abacavir 3TC was not as successful as patients with tenofovir FTC. Reassuringly, at least with the raltegravir and dolutegravir treatments given in this study, there was no evidence of that decreased antiviral activity. Next slide. So it takes me to the newest data on dolutegravir, which is actually in naive study subjects, which is the single study. And the single study looks at a very interesting comparison because it's really comparing completely different regimens. One regimen is abacavir, lamivudine, plus dolutegravir. So fixed dose abacavir, lamivudine, plus dolutegravir. And the other regimen is tenofovir FTC efavirenz, or a tripla. So we're used to seeing a lot of studies now where one thing is different, but here all three things are different. It was a blinded study. It was very well powered for its non-inferiority design. As we've mentioned multiple times now, very typical patient profile for the kind of people in studies right now, meaning relatively healthy, higher CD4 cell count, etc. And the study results are quite interesting. What they show is that the dolutegravir abacavir lamivudine arm was not only non-inferior to the tenofovir FTC efavirenz, but it was statistically significantly superior. And this is something we have not seen before, which is that in the primary endpoint of a study compared with Atripla, that you actually have another winner. So it's a kind of a landmark event. Another thing that's notable in this study that I think is worth just mentioning again, in many but not all studies of tenofovir FTC efavirenz, you have a better CD4 response in the comparator arm. And in this study, it was particularly marked, as shown here. There was a difference of nearly 100 cells, which is, not just statistically significant, but one could argue, well, who knows, maybe clinically significant. But anyway, it was just something that was a little different from our usual, where we say, oh, well, 30, 40 cells, maybe statistically significant, but not clinically. But anyway, it was a pretty big difference. Okay? Now, I'm going to mention the adverse events here because when you really drill down on the study results here, this is what ended up driving the superiority of the dolutegravir arm. Virologic failures on the Atripla arm, as we know from multiple studies of Atripla, were extremely rare, and they were extremely rare with dolutegravir bacavir imivudine. But the discontinuation rate due to side effects on the tenofovir FTC efavirenz, the Atripla arm, was actually very high. It was about 10%. And so that actually led to the statistically significantly better performance of the bacavir lamivudine plus dolutegravir arm. And that is actually something that Cal mentioned earlier in the STAR study with the lower viral load stratum of tenofovir FTC rilpivirine. So we're starting to see some examples where the adverse event profile of tenofovir FTC efavirenz, our gold standard for treatment, is actually bettered by some newer options. Okay, next. The other thing I want to mention is sort of summarized here, and that is the resistance profile in these treatment-naive studies of both dolutegravir, both compared to raltegravir and compared to efavirenz. Important things to notice on this. The most striking thing to notice is that at least among the dolutegravir-treated patients, there was no emergent resistance. We're not used to seeing that in clinical trials. We've seen that in boosted PI strategies, but certainly not in integrase inhibitor studies, and that's pretty amazing. One possible explanation for this is that dolutegravir has a higher resistance barrier than our existing integrase inhibitors. That's one possible explanation. Another possible explanation is that the criteria for virologic failure in this study were so stringent that they were able to intervene more rapidly and therefore end up getting the patients off their failing treatment more quickly. And the reason I say that, at least as a partial explanation for this, is when you look at the rates of resistance in the comparator arms, the raltegravir arm and the Atripla arm, they're actually very, very low, especially in the raltegravir arm. So very little resistance in either treatment strategy here in this study. So I'm going to now talk about dolutegravir in a different strategy, and we had such an incredible phase of HIV drug development in the late 2000s that treatment-experienced patients with highly drug-resistant virus, most of them are virologically suppressed now. Very few patients right now who take their medicines who are not virologically suppressed, but there are some out there, and for them, I think this is actually their biggest hope. This is dolutegravir in patients who have a history of resistance to either raltegravir or elvitegravir. So there are people who have documented failure on these drugs and documented resistance. Now they could be current resistance, meaning you find it on screening in the study, or it could be historical resistance. I think it was about 2/3, 1/3 in this study, and this is the so-called Viking 3 study. There was a period of 7 days of monotherapy where they just had replacement or addition of the dolutegravir and then continuing the background regimen, and then they optimized the background treatment. And here's what the results showed. Next slide. An amazing 2/3 of the patients in this study achieved virologic suppression, which is really extraordinary because these patients, and we know this because we're a study site for this study, had unbelievable degrees of antiviral resistance. Imagine what it would take to fail an integrase inhibitor-based regimen in 2011, 2012. And so that is very, very encouraging. And the other thing that is important here is that the dolutegravir was really acting as the major active drug, as shown by the multivariable analysis, that activity of dolutegravir was the leading predictor of success here, not the optimized background regimen. There was a resistance pattern that appears to impair response to dolutegravir somewhat, and that's the 148 mutation with a bunch of others. That seems to be the bad integrase profile for patients who are going to be salvaged with dolutegravir. So the clinical message for our patients, for our colleagues, is that if you have a patient who's failing an integrase-based regimen, one should A, obtain genotype information to see whether they've got resistance, and B, if they do have resistance, get them off that sooner rather than later so that they don't evolve into this highly dolutegravir resistant variant. Next slide. So to summarize what we know about dolutegravir so far, at least some of it, in these two studies in treatment-naive patients, it was non-inferior to raltegravir with plus 2 nucleosides, and it was superior to co-formulated tenofovir to efavirenz. It was this result, as I mentioned, was driven by better tolerability, which is an excellent thing. Very well tolerated, very favorable safety profile. It also, interestingly, increases serum creatinine by 0.15%. It also inhibits tubular secretion of creatinine. Who knew that all of our HIV drugs, or so many of our drugs, would do this? It does it by a slightly different mechanism of cobicistat, but I'll leave that for the nephrologists. And it's active versus many of the elvitegravir and raltegravir-resistant viruses, which gives it a role in salvage therapy. And then we're hoping that there will be FDA action on this drug in 2013. And in addition, I should mention that right now there is an expanded access program for people who need it. So I'd like to finish up now by just talking about stuff that's sort of way out there, and that's this whole cure strategy. And really what I'd like to highlight is some work done by some of my colleagues at Brigham and Women's Hospital. In particular, Tim Henrich, working in Dan Kuritzkis' lab, taking a look at, since he knew that there was this one person who was cured through a bone marrow transplant. Now that famous Berlin patient who now lives in the United States, who got a CCR5 negative donor when he got his bone marrow transplant for leukemia, Tim had this question, well, maybe it's not the CCR5 negative donor, maybe it's all the treatment, the bone marrow transplant. It's the conditioning and the wiping out of the reservoir and the radiation and who knows what else. So he went to stored specimens of two people who'd had bone marrow transplants who were HIV positive, both of them long-standing HIV infection. Let me just summarize briefly their clinical status. Excuse me. The first patient was perinatally infected, and so he'd had it his whole life. Excuse me, just one moment. And he had a history of Hodgkin's disease, which was not successfully treated. He then relapsed and required an allogeneic bone marrow transplant. And the donor was not CCR5 negative. And the important thing is he was treated the whole time with antiviral therapy. Never went off his antiviral therapy. So he was virologically suppressed the whole time. Just of note, the patient was a heterozygote for CCR delta 32 mutation. So whatever that's worth. So then the next patient, excuse me, has some similarities. Next. He also has that's good, leave it right there, go back, thank you. Long-standing HIV infection dating back, decades, and he also had a series of malignancies that led up to myelodysplastic syndrome, required a bone marrow transplant for myelodysplastic syndrome. Again, got a allogeneic reduced intensity stem cell transplant, which was successful. Was receiving suppressive therapy the whole time, this time tenofovir FTC raltegravir. And he too, just by chance, is a CCR5 delta 32 heterozygote. So Tim looked at these individuals, looked at their blood samples, and I'll show you the assays he did on the next slide. He tried to detect virus using standard HIV RNA. No detectable virus. Using the single copy assay, no detectable virus. Using this viral outgrowth assay that is basically positive in pretty much every patient who's receiving antiretroviral therapy, maybe some exceptions, no detectable virus, no genomic DNA by real-time PCR, and then in addition, no evidence of replication, looking at 2 LTR circles, and finally, they're looking at HIV antibody titers, which are declining over time. So these are very interesting patients. Now, I want to emphasize they're still on suppressive antiretroviral therapy, but they are not identical to other people who are on suppressive antiretroviral therapy. There is, I think, very convincing evidence that their viral reservoir has been reduced. But are they cured? Next slide. So I think the answer to that is we don't know. And clearly what these investigators need to do and what they're planning to do are further investigations, including tissue sampling, large blood volume sampling, and then also potentially treatment interruption. And that is going to be very, very interesting. I just want to mention that there are some other cure strategies being investigated, not related to bone marrow transplant, of course, because we can't do that for people because it's just too risky. And they involve things like use of histone deacetylase inhibitors, HDAC inhibitors, and which to sort of stimulate the latent reservoir and then eliminate it, and then also use of genetic modification of cells so that they become resistant to HIV themselves. So anyway, a very exciting research agenda for cure, and something certainly our patients are asking us a lot about, even if we can't provide it to them quite yet. Okay, and that's my remarks.
That's a nice summary. Thank you. So one question here that we've not asked is, can quad be used with Incentris?
So quad actually has in it an integrase inhibitor already, which is elvitegravir. So Icentris, which is raltegravir, is not necessary. So the answer would be should not be used with Icentris.
Let's see. How can I get the course on demand to do it again? I guess the people up front will have to satisfy that question. And I think that, well, that summarizes all of the questions that we've had. So, Cal, timeline on the tenofovir derivative.
Excellent question. So, of course, I wouldn't necessarily know that. Of course, it's up to Gilead and its work with the FDA. But what I can say is the phase 2 results at week 24 are already now in the public domain. Certainly, we'll all have a chance to see them publicly at a meeting, I'm sure, next year. But phase 3 is, of course, what would lead to approval. And as I understand it, phase 3 is either underway or about to be underway and enrolling patients. And if the phase 3 results confirm phase 2, which is usually the case in our field, I would expect that this drug is perhaps 18 months away from clinical use. Gilead certainly has already described in previous years their intent to use TAF, as is being abbreviated, TAF, instead of tenofovir in the quad, in potentially Complera, in a single tablet that allows us to combine darunavir with cobicistat, with FTC, and now TAF, because the 800 milligram tablet of darunavir is now available. The amount of milligrams of all of the 3 others allow us to create a standard 2-nucleoside plus boosted PI regimen for the first time as a single tablet. That's going forward as well. And we all expect to see some phase 2 results next year, so that we'll have a plethora of options in which this new drug would be available, and hopefully will address the concerns we have in the use of tenofovir with a booster, which is this low level of renal event, this tubulopathy. And if it decreases that tubulopathy from the 4 cases you had to fewer than that, that would obviously be really exciting for the field.
Another thing that would makes it valuable that we tend to underestimate, since we're not the people taking the pills, is that this has such a smaller milligram size that the pill, the co-formulated product, would be much smaller. Already, actually, patients seem to like Complera just for that reason more than they like Atripla, and because the pill size is much smaller. And one of my patients who was actually taking unco-formulated ropivurine, it's really, really small. It's a very small.
It's a tiny. You got that little.
Sure.
So it sounds like it's going to actually totally supplant tenofovir if everything goes the way we would predict it would go.
Well, it's an interesting question. I think, as the field continues to improve, we have abandoned drugs, right? There are drugs that we used to use all the time, and now we essentially never use. So I think that's the beauty of this field, is how rapidly we've been able to have advantage of these newer molecules. I mean, there are certainly protease inhibitors that a decade ago were the mainstays of therapy and are now invisible from our field. So it's pretty exciting.
Oh, so dolutegravir, what's the time?
Dolutegravir? Yeah, we think dolutegravir, sometime in calendar year 2013 is a reasonable estimate. And that's important for that small subset of people who really don't have options right now. Everybody who does HIV care looks at their patient panel, and most of the people who take their medicines are suppressed, and most of the people who don't take their medicines don't have a whole lot of resistance. But there is that subset, mostly from the 1990s, early 2000s, who just can never get suppressed because of serial monotherapy and drug resistance, and some of them have integrase resistance, and dolutegravir really helped them. And it also looks very promising as an initial therapy, certainly, both with tenofovir FTC and with abacavir lamivudine.
And with rilpivirine, in a patient that had a baseline viral load of 120 or 1,000 or something like that, you make it sound like now there's sort of a level playing field.
Well, Cal presented the data on the STAR study. I personally would not use rilpivirine or Complera in that setting, because there are so many other options. We didn't see that decline in antiviral activity with quad, and they certainly don't see it with Atripla. But the thing is about this tolerability issue. For the patients with the low viral load, when you lay out the options for them, they often say, I want that one, and they choose the Complera. I mean, it just seems it's very popular in the low viral load patients, but I wouldn't in 120,000. But one thing that you didn't mention in the switch study is that they did an analysis where they looked at the baseline viral load. People who started with over 100,000 and then were suppressed on a boosted protease inhibitor. That didn't seem to matter if they switch to Complera.
One suppressed,
One suppressed, yeah.
One suppressed,
One
yeah.
suppressed.
It's everything's so much easier when they're
Oh,
suppressed.
no kidding.
The question is getting them suppressed.
Monotherapy and everything.
So let me. I'll take Paul's challenge on the 120,000.
Yeah,
It's a great question. I think it is really the question of the STAR trial. What do I do for that person? I think it's. I guess I would look at it this way. If I do a screening viral load on a patient and it's 90,000, we know that there's noise to the test. If we recheck it, it might become 120,000,
Sure.
It might be 60,000. So if I have 90,000 today, can I trust rilpivirine Complera? And realizing that it might bounce higher.
Yeah.
And I think until when we had Echo and Thrive, I think many of us would say if it's going to bounce higher, I have reasons to be nervous. I think this study would allow us to at least feel confident that even if it's 90,000 today and 120,000 tomorrow, this regimen should work as well as Atripla, albeit with a little bit of a difference in the risk of resistance, but still overall efficacy was the same as efavirenz. And so I think it's comfort around the higher end of the first 5 logs that the study reinforces. Not going above 5 log, I mean, I agree with you. We have enough options that you don't have to. It's well tolerated. But if the GFR on your patient is below 70, what's the right thing to do?
The good news is we have, we have 3 options for single pill treatment, which the patients love. I mean, it's interesting. We're doing a very interesting clinical trial that looks at a novel regimen of Maraviroc, boosted darunavir, and emtricitabine as the initial regimen, and 3 active drugs. And the really primary interest is something like this. Going to be safer for bones, going to be safer for the kidneys, going to have better immune activation because you're using the Maraviroc. But the sell to the patient is tricky because they know that the single pill options are there. So we offer clinical trials to pretty much everyone. Some people want to do it just to advance the field, but other people say, nah, I'll take a single pill.
Yep. No, it is obviously tracked, and we've and you and I both, of course, addressed that there's one more piece of it, which is the single tablet has not just issues of appearing kind of attractive, but there are data to support that refills are a little bit more likely to be consistent on a regular basis when we get rid of the multiple options in multiple bottles, and that there are patients who we all know will call in for refill of 2 of the 3 of their meds in their regimen, but not all 3. And what to do about that other than to say, obviously, something's out of sync here. and the single tablet gets rid of that. So I think that whether the single tablet is boosted PI, whether it's integrase inhibitor, whether it's dolutegravir or darunavir, I think that the simplicity and building in protection against error has its own merits.
Yeah, it does. It does. I do predict, by the way, we'll learn something interesting from that novel study that I just
Sure.
said. But I also predict that a lot of the patients at the end of the study will probably switch to a single
The single
pill.
tablet, yeah.
So cobicistat, is that going to be available without packaging?
Sure. My understanding is that in 2013 we will have both single tablet cobicistat as well as elbapixant as
Yeah.
standalones.
Yeah.
So that'll be something next year. And I think it will allow us to address a piece of the puzzle that I think is lost a little bit in the studies that compare cobicistat to ritonavir. If I have a patient who's intolerant to ritonavir, can they tolerate cobicistat? That's not been studied, and having the separate standalone would allow us to study that. We have patients who are ritonavir intolerant. They look similar in a head-to-head, but that doesn't mean that one isn't better tolerated for a given patient.
Yeah, we'll see. The pill's smaller, at least as I understand it, and it does seem to have less in the way of lipid adverse events.
Right, so we'll see. More to learn on that one.
So how do you see the field changing in the next couple of years? We've got all these. We've got a pipeline. We've got some new drugs. We've got some squeeze to save money. Do you think?
Well, the squeeze to save money needs to be addressed, and what we need to do is if there is benefit that is measurable and affordable to the more expensive, usually newer approaches, then those should be taken. If not, if all things being equal, of course the less expensive approach is the way to go. And it really is going to depend more on what the payers tell us than what we decide in the exam room with the patient. So
The stakes are sort of high, though, aren't they? It's a lot different than a Lipitor, for example.
It's
I mean, resistance is the elephant in the room.
right.
When you start playing around with these drugs.
We've done these claims database studies, and I believe there was one just done in Europe as well.
That's right.
But we're basically the data fall out that this single pill is better. And one of my colleagues is David Bangsberg, who does most of his work now in resource limited settings. But there was a study he published a couple of years ago in the homeless population in San Francisco, one of the hardest to treat populations in the United States. And he found a real substantial benefit for giving them one pill a day versus a complicated regimen.
So one of the questions is there going to be a fixed dose of atazanavir and cobicistat
That is,
in the future?
That is actually at least announced as planned.
Yes, as well as the darunavir cobicistat standalone single tablet. That too is also announced. So we're going to have the options for PIs with their booster built in. And again, what to do with that will be the field. You could combine it with essentially anything with the new advanced tenofovir if it's available separately. So it's really going to give us a whole range of options that we haven't had to think about.
So, so in your clinics, are you starting to use a lot of the newer drugs?
So the answer is they have been much more popular than I expected.
Really?
Yes. So it has to do probably with the ephedrine speech that we all have gotten used to over the years.
Yeah.
The kind of, it's the first day or two, you might feel groggy in the morning, you might be dizzy at night, but just stick with it. Over the first couple of weeks, it gets better.
Yes.
And we all knew that it did get better for most people, but then there was that subset who long-term...
And it was a fairly large subset.
Yeah, it depends on how you look at it.
Was, yeah.
It's real. It's certainly real. It's not.
It's certainly real.
So one of the things I thought was so striking about the open-label study that Cal presented was 0 discontinuations.
For the CNS
For
stuff. I mean, we
CNS,
had 10 people discontinued on the rilpivirine, and I forgot to mention it. I looked at all 10 of those reasons, and there is not one reason that's given twice. In other words, one person, for example, stopped because they developed hepatitis C. Another person stopped due to fibromyalgia. So in those 10 reasons are things that probably have nothing to do with rilpivirine. It's really well tolerated. It certainly supports the fact that, as we were kind of discussing earlier, which is what's the role of even a generic ATRIPLA in an area where we have regimens that seem to be better tolerated? And I think that's hopefully something that our payers will allow us to take advantage of.
So we're sort of getting up to the point where we've got 90%
Oh, yeah.
success rates
Yeah.
and almost no fallout.
So you know, to my mind, there's a right now, you got the 10% of people we care for who just don't take their medicines,
Yeah.
and it doesn't matter what we give them, it's not going to work. And then another, 5 to 10% who probably are on the margin, and maybe it's comorbid medical conditions or maybe it's psychosocial issues. But if we could just get the right thing for them, we'll do well. And then the rest of the group, there's so many options. They'll take their meds and they'll be successfully treated. It's remarkable.
Yeah.
So, and that's been shown in cohort studies too.
Yes.
You know, the vast majority of people in care now are virologically suppressed. The people who are not in care are a different issue.
Would it be fair to say that the pipeline is slowing down
Oh,
a
yes.
lot?
That is true.
Yes, especially for novel approaches.
Yeah, I mean, there is another entry inhibitor we didn't talk about today, Cenicriviroc. There's another nucleoside being developed. There are a couple of other things being developed, attachment inhibitors, but certainly the pipeline is fewer, in part because these therapies we have are getting so much better than ever before. It's hard to know if you can do even better.
Yeah. So, and of course, we'll have a cure in 3 years, so that'll be...
Are you
Okay.
channeling Margaret Heckler then?
All right. And are either of you using monotherapy at all?
I assume you mean protease monotherapy.
Protease
Yeah,
monotherapy,
boosted monotherapy.
yes.
No.
After they're suppressed.
No.
Yes.
So I use a modification which includes lamivudine or emtricitabine, because usually what I'm trying to do in those patients is avoid tenofovir and avoid abacavir. If they've got renal issues or cardiovascular issues, they have a background history of NNRTI resistance, they're not good, so they're not good candidates maybe for an integrase inhibitor, and they've been stable for a long time on a boosted protease inhibitor. Just that the strategy of dropping out the potentially offending drug is a way to go. And it's been actually now reported that that's a reasonable strategy.
And
Yeah.
you, Cal?
Well, I do have patients on it, and it's a much
Is it
more-
always a PI?
It's always been a
boosted
boosted
PI.
PI, and it's almost always been boosted darunavir, and it is one of the reasons why the darunavir cobicistat single tablet's going to be an interesting one to watch, because
Yes.
the data from the studies has been pretty impressive, and so
That'd be
it'll
one
be a
pill.
topic for our future. I'm quite sure.
Well, it's kind of interesting to watch this field. It's never stopped, does it?
That's what makes it
It's
so-
been going on for a long
so-
time,
so
and it's gotten
enjoyable.
very exciting, and it doesn't seem to stop. Well, I think we've run out of time. I want to thank both Paul and Cal for joining me in this discussion. I'd also like to thank Genentech and Cubis for their support for this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. I'm John Bartlett, and thank you for joining us.